Can we start, sir?
Yeah.
Can start, sir?
Is it okay? Is it audible?
Yeah, yes.
Okay, good afternoon, everybody. And particularly, let me thank you, Dr. Radha Krishna, for inviting me to this meeting. It's a good initiative. I congratulate you. I would be confining myself to the level of postgraduate surgical residents. And hence, I would be trying to, inflict more on principles, more on concepts, open up certain small debates, and then trying to get a basis for our understanding about thyromegaly. When you sit in the clinical practice, you would see a lot of patients do come and tell you that they have a thyroid problem. Most of them, if you just take the history, most of them either would have been diagnosed having some functional abnormality of the thyroid, which is most often is going to be hypothyroidism. Now, I would normalities of the thyroid as one set wherein we are not able to, it is completely medical, and hence I will not address this at all in the present talk. As far as thyromegaly is concerned, it is an anatomical disorder which certainly needs to be handled by a surgeon. And on a gross note, you can have a uniform thyromegaly or a nodular thyromegaly. Uniform thyromegaly is also not probably a big surgical issue because you have a fundamental background issue which gives rise to a uniform thyroid enlargement. Maybe physiological, maybe endemic, maybe familial, maybe hypothyroidism, hyperthyroidism, all the colloid goiters. These are all, unless and until it assumes a huge volume and hence possibly a cosmetic reason, is unlikely to come to the surgeon. And hence I would again, for the time being, would leave the uniform thyromegaly and concentrate on nodular thyroid enlargement. Here, the thyroid could be enlarged irregularly as different nodules, size of which could be variable, or the thyroid could harbor one single nodule. So let's start with a single nodule in a thyroid on clinical examination. Very often, these patients come to you, to the clinician, for a swelling in the front of the neck, either on the left side or the right side, upper part, lower part, or the isthmus. A single swelling which is visible to the patient, which has been of some concern to the patient. Many of them may be asymptomatic. Some of them may have pain. Some of them may have some other rare symptoms like pressure symptoms, voice change, difficulty in swallowing, depending on the size of the swelling and based on the pathology of the swelling. Say, for example, you could have a pain in an inflammatory disease. You could have a pain in a bleed into a cyst or a tumor. You could also have rare symptoms like in thyroiditis. You could have some dysphagia because of the local inflammation. You could also have some pressure symptoms, even possibly a situation of little bit of dysphonia as well. So if you look at these solitary nodules, we need to find out whether these nodules are really solitary in nature or they are part of a multinodular disease and this nodule has attained a larger size. So what we call in strict sense a solitary nodule is that one which is in a literal sense solitary, that even by clinical examination or by ultrasound, you don't have any other nodule in the thyroid. So this is by definition of a solitary thyroid nodule. Sometimes you would see this nodule as part of a nodular disease, and this could be a dominant nodule where the rest of the nodules have not either reached visibility or even palpability. You could actually find out through ultrasound that there are many other nodules in the thyroid which are very small in number, which are small in size, which has not been able to attain clinical notice, be it palpation, be it visibility. So we will first start with strict solitary nodule of the thyroid. This could be either a cystic swelling or it could be a solid swelling. Cystic thyroid swelling very often is tensistic, and the classical sign of a fluctuation in a cyst may not be elicitable unless and until it attains a large size and the fluid content is much less than what it can be stretched to the maximum. So very often the firm cystic kind of a reason will be, on clinical examination would be appearing as firm. But however, if it is a solitary, if suppose it's a solitary nodule, it is important that we rule out the possibility of a cystic solitary swelling. In that you have two basic cysts. One is a simple cyst, which is often a unilocular cyst with a clear fluid collection with thin wall, and clinical diagnosis of a solitary swelling, possibly with a cystic nature. Ultrasound clearly gives an idea that it is a cystic swelling with thin wall would be the diagnostic feature. If you put an aspiration needle, it yields clear fluid. If the cytology is negative for malignancy, it is clear in nature, and if it doesn't reappear in reasonable period of time, this can be taken as a benign cystic solitary cyst of the thyroid, and the treatment would be either wait and watch, or if aspiration is complete, it might disappear. Situation where you need to interfere surgically in these kind of situations boils down to a fast recurrence of the cyst after aspiration, or can have a unclear fluid or a hemorrhagic fluid, something of that kind. Otherwise, you don't require a surgical treatment for a simple cyst. Now we come to a complex cyst. A complex cyst is defined generally as a cyst with irregular borders, hypoechoic to start with. It may have a solid and soft cystic component. It may have an increased vascularity around. And when you put a needle into it, you could actually get hemorrhagic fluid, an altered blood fluid. Now, an ultrasound is mandatory to distinguish between a solid and a cystic swelling, as well as between a simple cyst and a complex cyst. And the reason why we do an aspiration cytology in a complex cyst directed to the solid part of the complex cyst is to rule out malignancy. If the cyst as per aspiration reappears, and if aspiration cytology cannot rule out malignancy with confidence, this is a situation where surgical option need to be considered. There will be confusing reports and treatment modalities like sclerotherapy, injection, etc., etc. I'm not getting into the merit of each one of them because it has got a lot of controversy, and you cannot have a balance, and you would have to treat these things on an isolated basis. By and large, simple cyst, benign, wait and watch, size, aspiration can be done. And if aspiration is clear and the cytology is negative, if it is not recurring, it can be a complete treatment. A complex reappears within reasonable time, and if it is symptomatic and if it is giving a problem, probably surgery required. Complex cyst, again, if you rule out malignancy, it can be left alone. Repeat aspiration may be read after an ultrasound evaluation after enough time, so much so that you rule out malignancy again. Failing, and if the swelling reappears, then surgery would become mandatory. So I'll leave the cystic swelling, solitary cystic swelling right now and move on to solitary lesions of the thyroid. Do I take questions now, Radhakrishna, or do I take questions later?
Yes, sir. Anytime, sir.
Yeah, depends on the crowd. You feel that if any questions needs to be answered, where we have finished the solitary cystic lesions of the thyroid, we can actually take questions at this point.
Anyone who wants to ask a question, please raise your hand and unmute your. Yeah, Mayur. What is the question you want to ask?
I have seen the question how many times. I would think that an interval of, if it is rapidly swelling, rapidly reappearing, probably more frequently. Otherwise, I would think 6 to 8 weeks, you can wait for a reaspiration. 3 or 4 aspirations you do, and if it recurs again, and if symptoms persist, we would operate. Would that satisfy Mayur?
Pradeep, what is your question? Pradeep Joshua? Yeah, anyone else? Rajender?
So,
Yes.
if the malignancy cytology is negative, but the patient is presenting with pressure symptoms, is that still an indication for removal of the cyst?
Yeah, I already covered that. If there is a recurrence, which is cosmetically worrying, if there is pressure symptoms, certainly yes, it's an indication to go in.
The Mayur have anything to say?
There was a question on, can we wait and watch? Yes, if the if the cysts are small, and if it is not causing any pressure symptoms, if it's not causing any cosmetic problem, probably you can wait and watch for some time, reassess the patient. If there is a change in symptomatology, re-evaluate the patient if there is an increase in size of the swelling. Okay, then we move on to the solid component, solitary nodule of the thyroid. Okay, so a solitary nodule of the thyroid could be benign to malignancy. It could be follicular adenoma, it could be colloid nodule, it could be malignancy. So there is a large spectrum, and I'm sure that all the students of surgery today say of a quadruple assessment for thyroid, just like a triple assessment in breast, which consists of clinical examination, ultrasound, fine needle aspiration cytology, and or tissue characterization otherwise, and go in for a thyroid function test to complete the 4 parts of your clinical total evaluation of this nodule. And I'm not going into the details of the present Tirad's grading system, because it's very well available before every student. Please go through that. Now, our challenge in front of us would be in a small set of patients whose FNHC would be reported in a very confusing manner, ATP of uncertain potential or anything of that kind, which would demand further tissue characterization following a imaging modality at some point of time, sooner than later. So first, let us do our time on the malignancies of the thyroid, which is going to be more worrisome. If you look at the whole malignancy of the thyroid, it can be very well divided into primary malignancy of the thyroid and secondary malignancy of the thyroid. Secondary malignancy of the thyroid is not very uncommon. Keep that in mind and leave that for some time. We will concentrate on primary malignancy of the thyroid, which can be divided into follicular cell in origin, parafollicular cell in origin, and others. Those in follicular cell origin are papillary carcinoma, follicular carcinoma, mixed papillary follicular carcinoma, Hurthle cell carcinoma. These are the common varieties in a well-differentiated carcinoma of follicular cell in origin. Then there will be another group called the undifferentiated follicular cell neoplasms, which are anaplastic carcinoma or even sometimes undifferentiated carcinoma. Then parafollicular cell in origin would be our medullary carcinoma thyroid. Other rare malignancies include lymphoma, which could be primary, or rare malignant neoplasms like squamous cell carcinoma, angiosarcoma, etc., etc. When you look at the whole spectrum of treatable thyroid malignancies, which presents as nodular thyroid diseases, follicular cell malignancies of differentiated variety, and parafollicular cell medullary carcinoma are eminently treatable, having an excellent prognosis. So it's our duty to, diagnose these things earlier and take it forwards. So imaging plus tissue characterization by FNAC would be your decision-making guide. Theoretically, as you all know, possibly these lesions are very docile lesions having very slow growth rate and hence has got an excellent cure rate when you treat it completely. And hence came the gradings in terms of the prognosis. Low risk malignancy, medium risk malignancy, and high risk malignancy, or a low or high, depending on which grading system you follow. Again, you have many of them available in literature, from Ames grading system, Aegis grading system, MICAS, Sloan Kettering. There are so many of them available. I don't want to go into the merits and demerits of any of these lesions. Though there is a distinct reason, argument for anything less than a total thyroidectomy in a low risk group, having got a patient who is suspected to have malignancy and having established that there is malignancy, I'm really skeptical about the number of surgeons who would do anything less than a total thyroidectomy, or any patient, educated patient, who would accept anything less than a total thyroidectomy. I'm not into a controversy, but by and large, a histologically or a cytologically proven malignancy in thyroid, though there will be an existence of a low risk malignancy, and the group who would be arguing for anything less than total thyroidectomy, practically most of these people will go for a total thyroidectomy. Now, how do we work up this patient? These patients certainly will have an ultrasound to start with. And as I mentioned, the TIRADS, TIRADS come into the picture. FNAC, you have now the Bethesda system coming into play. Now, reporting system. So in the TIRADS combined with Bethesda, you have a high rate of malignancy. You have to take this patient for surgery. And prior to that, you need to do a thyroid function test to make sure that the patient in a euthyroid status. Hypothyroidism would demand a correction. It is not a volcano on which we are sitting, and hence you can take reasonable time to correct hypothyroidism. All of you must be knowing the reason why hypothyroidism needs to be corrected, because the anesthesia, the patient will take long time otherwise to recover from anesthesia. So hypothyroidism needs correction. Similarly, hyperthyroidism also would require correction for the simple reason that any procedure, any anesthesia, any stress could precipitate this patient going in for a thyroid storm. So you need to control both hypothyroidism and hyperthyroidism in solitary nodule if you are going to go for surgery with proof of malignancy. Reasonable time can be taken. The next investigation that needs to be done is a vocal cord status analysis. And I'm sure that all of you know the reason why vocal cords needs to be assessed in every single patient before a thyroid surgery is you could have 1 to 2% people in the population who would have silent asymptomatic vocal cord palsy, well compensated, and you will not have any problem in speaking, and you will never see that these patients have got a vocal cord issue. But if post-operatively, for any reason, if this patient has to have a vocal cord assessment by a laryngoscopy, if this particular palsy is found out, it would be attributable to your surgery and you would be medico-legally held liable. So it's a good idea that all people who are going in for a thyroidectomy needs a vocal cord assessment to assess the vocal cord and rule out the possibility of a silent asymptomatic vocal cord palsy. This will also, make the surgeon very careful to locate, isolate, and preserve the lateral nerve on the contralateral side, because that is the vocal cord on which the patient is going to have its vocal, I'm not saying that you should be not careful in other situations. It would be a situation where the operating surgeon would be made extra careful in isolating the retrolaryngeal nerve. So having done all these things, and the patient now needs to go for anesthetic fitness and the other investigations that are required for fulfillment of administration of anesthesia, like a chest X-ray, ECG, maybe a cardiac evaluation, maybe an echo, depending on the age, ECG status, etc., etc. I'm not getting into that. Now, where do we do surgery? We know for certain that we already have mentioned that there is a group who would believe that strongly total thyroidectomy is not a procedure which needs to be done in all cases. The arguments which they would make would be it is a very docile malignancy with long survival rate, and hence, a more morbid procedure like total thyroidectomy need not be done. The counter arguments for doing a total thyroidectomy would be most of the differentiated follicular cell neoplasms, particularly papillary carcinoma, is well known for its multicentricity. So you do not really know whether the opposite side is having a focus which is not visible, more palpable, not even diagnosable in an ultrasound or any other modality. So there could be a multifocality, hence the leftover gland may harbor the focus of malignancy. Number two, in your clinical examination following the surgery, it takes a lot of time to detect these. And if you want to use any other form of early detection like thyroglobulin, it becomes a futile exercise in the presence of leftover thyroid tissue. It also becomes a futile attempt, or it would require a large volume of I-131 to ablate the leftover thyroid. So that is not going to be a practical solution. For these reasons, it is better that you have a total thyroidectomy upfront. The other reason for the people to educate total thyroidectomy is, if you have got a recurrence, either a local recurrence or a nodal recurrence, it would render a second surgery more difficult, and hence the first chance would be your best chance, and total thyroidectomy would be done upfront. So this is a rationale for doing a total thyroidectomy. Maybe a decade or two ago, all total thyroidectomies for differentiated, well-differentiated papillary carcinoma thyroid is uh, contemplated along with a total thyroidectomy. Central compartment neck dissection was a compulsory thing. And this is just like any other regional nodal dissection. Regional nodal dissection is the most morbid procedure. If you look at carcinoma breast, the regional lymphadenectomy has given a lot of problems, and hence people are trying to limit that to, if possible, not to interfere, if possible, minimal interference as a sentinel node biopsy. Same is the case with inguinal lymphadenopathy. Same is the case with retroperitoneal lymphadenectomy. So lymphadenectomy is the one which gives rise to morbidity in any disease. Likewise, in central compartment, neck dissection was considered part and parcel of a total thyroidectomy for a well-differentiated follicular carcinoma of thyroid. I mean, follicular neoplasms in the thyroid, particularly papillary carcinoma. So it has evolved its usefulness and what is being done today. Previously, it was all papillary carcinoma thyroids used to have total thyroidectomy with bilateral central compartment neck dissection. It later on got replaced by ipsilateral central compartment neck dissection. And today, it is not necessary to combine a total thyroidectomy with a central compartment neck dissection unless and until there is a clinically palpable lymph node in the central compartment or radiologically suspected metastatic node there, or on table, this experienced surgeon feels that there is a central compartment neck node which is significant. Otherwise, now it is not mandatory except in lesions more than 4 centimeters in size. Otherwise, neck dissection is becoming less and less in thyroid also. So the current view would be ipsilateral if clinically, radiologically, or on table, if the patient, if the lesion, if the nodes are found to be significant, or if the nodule size in the thyroid is more than 4 centimeters in size. Now, preoperatively, can you locate the lymph nodes and predict its metastatic potential? Yes, with the present ultrasound and the technology available, with the experience of the the radiologist, it is possible to predict whether the lymph node that you see is metastatic or not. The normal shape of the lymph node is described as reniform, kidney shaped, and it is normally more tall than wide, isn't it? It is more tall than wide. Now, when the metastasis occurs, the lymph node, as you know, gets swollen and the dimensions changes. It becomes wider than taller. It loses its fatty hilum. It loses its perinodal halo. It may have little microcalcification. The vascularity could be increased and there could be central necrosis. If these sonological findings are present, these are significant nodes which are looking radiologically potentially metastasis. This is what I was referring. If your radiologist is going to describe these kind of lymph nodes, these lymph nodes form part of your central compartment neck dissection. So this is an indication. Now, let us have a patient who has had a nodule. We have decided to go for a total thyroidectomy based on your FNAC and your radiological assessment that this patient needs a total thyroidectomy. You go in, you find total thyroidectomy, a safe procedure, done that. Central compartment, you see, you put in this criteria, you have, you need to either go for it or decide not to go for it. Lateral neck nodes is a different ballgame. They are addressed only when they are clinically or radiologically present. Routine lateral compartment neck dissections are not combined with a total thyroidectomy for prophylactic reasons. So this is how it stands. Now you get the pathology report. The pathology report can be of varying types. You have a routine, normal, routine, report saying that this is a papillary carcinoma or a follicular carcinoma or a mixed papillary follicular carcinoma. In a case of papillary carcinoma, as we all know, it has got predominant lymphatic spread compared to follicular neoplasm or follicular malignancy. And it is here that you actually apply your grading system. There are patients whose nodule size is less, no metastasis, the age is good. These patients may not require, a high grade of adjuvant treatment. I will come to that in a minute. So these patients are a low risk group, and there will be, or for practical reasons, we need to identify the high risk group with high potentials of malignancy and spread. So this is where we need to have the distinction between the two. Multifocal lesion, familial lesion, certain special varieties like tall cell variety, columnar cell variety, etc., are aggressive in nature and hence would certainly go in for adjuvant therapy in some form or other. We will come back that in a minute's time. So once the patient is subjected to total thyroidectomy, you wait for the pathology report to come in. Now comes the question of sending this patient for I-131 ablation. So the world would be divided into two as far as the nuclear medicine is concerned. There will be one group who would say that ablation should be after deciding whether there is an adequate residual tissue that is left over or not. So many centers follow what is called an I-131 low dose uptake scan to decide whether there is enough thyroid tissue worth ablating. The other group which believes that low dose iodine scan is not required and low dose iodine scan is hazardous to the patient, believes that a second exposure to an I-131 or radioactive material would not be as effective as the first one in what called as the stunning effect, and hence it is better to attack the gland from upfront for the first time with the full ablative dose. So that's the second group. You can, depending on what your institution follows, both the groups have got their own values, and I really don't want to go into the details and of the debate of these kind of things because these are possibly too much hair splitting. So all what you need to know is whether this particular patient of yours needs to be referred to a higher center, a nuclear medicine facility for ablation or not. I'm seeing some questions in between. Thyroxine, whether it is to be started in upfront after the surgery. Majority of the people who follows the Western literature and would like to have the similar situation, if facilities are available in your center for immediate I-131 scan, when the TSH level is high, usually it takes about 6 weeks of time, it's a good idea to subject this patient soon after surgery, after waiting for 6 weeks, when the TSH is up at 30, probably to subject this patient for an I-131. But on a practical note, when there is a sparsity of centers of nuclear medicine and the facilities are not available at your doorstep, it may not be possible for every post-op patient to be sent for an ablation, and you may not get the dates for an ablation. So practically, many centers would start the patient on thyroxine suppression and then go for a planned I-131 uptake after getting a date for an ablation where he stops the thyroxine well ahead to make TSH high. I also saw a question, why not recombinant RNA, the recombinant TSH? Please understand, recombinant TSH is available. It is used, very sparingly used, because it's going to be extremely expensive, and very often it costs more than the surgical package of the patient, and hence cannot be used as a blanket therapy or a blanket dictum for every single papillary carcinoma thyroid. This is reserved to a group of patients who can economically afford it, who have got time as a constraint, and who the center has got adequate facility and low threshold and low volume of patients so that they can accept the patient just on referral. Majority of the nuclear medicine centers where there is a lot of work that is being done on thyroid or other malignancies, these people will have to wait sometimes 3 months, 4 months, etc., etc. So on a practical note, thyroxine to start with, followed by a definite, a date for an ablation is the practical solution if you took at the whole of the country as a single block. Yes, ideally, it should not be started. It should be after the I-131 scan or ablation, for which you need to wait for 6 weeks' time, or rather TSH to be high. But majority of the centers may not have that kind of a luxury. Now we have this uptake versus blind high dose of ablation, which also I have narrated. Now this patient comes back to you after an ablation or after an uptake. 2 to 5% of uptake can be left alone without an ablation. That is, some centers follow 2% uptake, some person follow 5% uptake. Either way, it's fine. What is the question coming in? Can you explain the concept? I didn't see it. Can you just complete that sentence? I can answer that. Anyway, while you're typing this,
Yes, sir. Can you explain regarding concept of active surveillance in micropapillary cancer?
Micropapillary carcinoma is defined as carcinoma where the measurement is less than 1 centimeter and it does not have any potential on life threat. So hence, these patients need not be put onto ablation. They just possibly can be left alone with a higher dose of TSH supplementation, suppression than after the surgery. It does not have any consequence of surgery or consequence in survival. Does that clear? Does that clear your doubt?
Abhilasha, are you okay with that answer?
Okay.
Now, what is your question? You have a question before sir continues?
Yeah. In having said that microcarcinomas do not have a bearing on the lifespan, I would find a subset of these patients whose multifocality and possibly a familial tendency would make them at a high risk. So by definition, microcarcinoma may not have much problem, but in the background where you have multifocality and also in a setting of a familial papillary carcinoma syndrome, that subset of patients, I would like to, address them differently, having a slightly higher behavior. So I wouldn't mind going in for some kind of an adjuvant therapy if a clinical situation clinical situation demands that. Next question comes in recombinant, the recombinant TSH, whether it is for high risk group. No, recombinant, even if it is a high risk group, it is not just like any other malignancy. It's again very docile when compared to many other malignancy. So I wouldn't place that even a high risk variety like tall cell carcinoma or the other the tall cell or insular variety of papillary carcinoma. They don't have the speed to kill a patient in few days time. So recombinant at a cost of say 70 to 90,000 rupees does not get justified by putting that money and advancing an investigation by 3 weeks to 4 weeks. It does not get advanced. But if somebody has got a money power, I will not hesitate. I will not stand in the way. I'm talking about the large number of Indian population, and I'm sure that senior people sitting here would agree with me. A post-COVID time where things are going to be very, 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 tight in our condition. These patients coming out even for follow-up becomes a very difficult situation. So we have to calculate the ways and the various aspects of it before we ask for a recombinant TSH in any case. Next question is, if planned for total thyroidectomy? I'm not able to get the rest of the question.
So if we have total thyroid, we have done a hemithyroidectomy, and we want to go for the re-surgery, the total thyroidectomy, we want to go for that. So how much time interval is to be considered and why?
$1 million question. It all depends on the surgeon and the center. Centers where thyroidectomy is a routine surgery, thyroidectomy where recurrent laryngeal nerves are routinely traced till it enters the larynx, probably one can go early in the post-operative period. You usually get your results by around a week's time to 10 days time, depending on the center. It is possible to go back in immediately after, but please understand that the second surgery is not a joke. You shall not put the patient under risk. So if your center is not having an adequate volume, if the thyroid surgeon is not experienced, I would request you to wait. No harm in waiting, because it's again a very docile malignancy. You may go back in at a convenient time where you find that the inflammation has completely subsided and you are a safe surgeon to explore the opposite side and identify the recurrent laryngeal nerve and then proceed. Okay, is that an answer to you? Is that sufficient for you?
Yes, sir.
Okay.
Yes, sir.
Yeah. So it all depends on.
Sir, second question is.
Yeah.
Okay.
Second
Sir,
question.
my second question is, can you please tell us about more often we are asked in the exam, how do you define a significant lymphadenopathy in the cervical or in the neck or the cervical lymph nodes? How do you call it as a significant lymphadenopathy?
Clinically.
So they asked the definition that defines significant lymphadenopathy in neck.
See, when clinically a lymph node becomes palpable, in a setting of malignancy, I would think that it is significant. Because an enlarged in the neck, normally you wouldn't get any neck nodes palpable, isn't it? In the setting of a proven malignancy in thyroid, any lymph node is significant. Now, that is clinically significant means nothing. You need to have an extra vigilance on this to radiologically assess. And I have given you the data, given you the features of a metastatic lymph node in a neck node, radiological features. Yes. Many people would be asking for centimeters of, size.
Right.
Some people will be very happy to have 1 centimeter size swelling lymph node being considered as significant. Some people might be very happy to hear a value of 2. To me, every single lymph node, if it is palpable, if the thyroid has proven, I'm talking about a thyroid which is proven malignancy, it has to be considered as significant, and it can be subjected to radiological analysis. I'm seeing some comments as 1.5 centimeters inguinal, 1 centimeter in neck, 2 centimeter in axilla, etc., etc. These are all arbitrary terms. These are all arbitrarily, and if you are taught like that, you may follow. But then, to me, if even you will not get. Trust me, you will not get a cervical lymph node in the central compartment 2 centimeter size to make it significant. 0.5 is significant in a central compartment. 0.2 centimeters may be significant in the central compartment. So you don't just go by the size and the measurement. So it's not the measurement that makes it, the features that make it significant. You find a 0.5 centimeter hard lymph node in the cervical region, it is metastatic. Size of the lymph node doesn't matter. Doesn't matter. On a clinical note.
Yes.
Okay. Some other questions were also typed in.
How to differentiate between anaplastic CA and lymphoma when FNAC can't help?
I have not reached that level. If you want me to answer that right now, I can answer. But then we are still with papillary, and I would like to take little more on papillary. Is that okay, or should I answer right now this?
Yeah, it's okay, sir. Let them ask
Yeah.
on papillary CA.
Yeah.
Anyone, please?
So one another question that has typed in: what you do when you have got a left or a hemithyroidectomy or anything less than a total thyroidectomy, and when do you think that it should be done? I think I've answered that question. And then, is there any difference between? I can't see that question fully.
Difference between terms adjuvant radioiodine therapy and radioiodine ablation.
No, in what one should understand what is adjuvant. Once you understand the terminology called adjuvant, then everything adjuvant really means that once you have done a curative manipulation by way of surgery, then potential risk of local recurrence, distant metastasis is taken care of some modality of treatment. Whether it is radiotherapy, whether it is chemotherapy, whether it is radioactive material, they all come under the category of adjuvant treatment. Does that make it clear?
The Dr. Onko, whoever it is, should answer this question. Yeah, he says yes. Yes, it's convenient.
Yeah. It's only, say for example, you have a breast that is being treated by surgery. There are occasions when you don't have to have any adjuvant form of therapy. Say for example, in a T1 disease, N0 disease, well differentiated in a postmenopausal who is ERPR positive, etc., etc., you may not require any form of therapy also. So if you are going to prevent a potential local recurrence, a potential distant metastasis by your manipulation using any form of therapy, that is adjuvant. So radioactive ablation also is an adjuvant therapy in the setting of a thyroid, where you are potentially trying to destroy the potential metastatic areas. This is what the ablation would mean. In a strict sense, actually, this is a little complex. You are not actually treating the disease per se. You are actually treating the normal cells with normal capacity to uptake the I-131, so that a futuristic multifocal disease is prevented. I hope that you understand what is meant by that statement. I hope the listeners understand that we are not treating the leftover disease. We are not treating the leftover disease. Leftover disease, if you really look at it, is cold nodule, if I'm putting in that term into the picture. They are not going to take up the iodine. So you are actually targeting your therapy to normal cells or near normal cells who has got a capacity to take up iodine and hence get destroyed. So it's not the disease that you are going to treat. If you are going to have worried about the disease that you have left over, this is a place where external beam radiotherapy also has got a role to play, which is a very underutilized modality of adjuvant therapy in thyroid. Majority of the people believe that every single thyroid is to be treated only with I-131. They don't have any other modality of treatment, adjuvant treatment in their mind. There are occasions when you may have to treat with external beam RT. Apart from, say, for example, medullary carcinoma extensive, there is a role for radiotherapy, or anaplastic carcinoma, there is a radiotherapy, etc., etc. So you would still have radiotherapy in certain other situations. So we have this patient ablated and the patient comes back to you, or you have not ablated this patient. I-131 ablation shows that there is no requirement for an ablation. I-131 uptake shows that there is no requirement for ablation. This patient, after having had a treatment completed in a nuclear medicine center, comes back to the clinician. Now, how do we follow up this patient? We need the patient to be started on TSH suppression dose of thyroxine. Okay, TSH suppression dose of thyroxine. And many people say you need to suppress the two different categories of patients in two different ways. The low risk would require TSH to be suppressed to the level of 0.001 and a high risk to be level of a 0.005 level suppression. So this is again a arbitrary debatable thing, but what you need to know at postgraduate level would be you need a TSH suppression dose of thyroxine, maybe 200 microgram to 300 microgram, and titrate to level depending on whether you have a low risk malignancy or a high risk malignancy. And after this, this patient is to go for a follow-up. Thyroglobulin is a favorite question, and thyroglobulin is to be done in patients with lymph nodal, with papillary carcinoma thyroid well differentiated as a tool for detecting early recurrence. Now, the value of thyroglobulin becomes relevant only in the presence of a complete removal of the thyroid and hence the total thyroid. That's number one. Number two, all thyroglobulin values need not be absolutely fine, because if you have got an elevated thyroglobulin antibody level, this could even be normal fallaciously because it's not able to find its way out. So an isolated thyroglobulin sometimes may not be acceptable to the examiner. Examiners would like to have you to know that in the presence of a thyroglobulin antibody, the thyroglobulin value may be fallaciously normal or subnormal. Okay, so it's a good idea to hint to him that you would also do a thyroglobulin antibody along with the thyroglobulin level. Please understand that thyroglobulin is also an expensive investigation. It costs something like 1,200 rupees, 1,000 to 1,200 rupees, and hence you are not at liberty to do this investigation every alternate weekend. So you judiciously span it. I would think that a high-risk category, I would think that we would go for a 6 monthly or at least a once a year thyroglobulin would be sufficient. Clinical examination, if you have got doubt, ultrasound and thyroglobulin would complete your follow-up. Many of the centers who have had this I-131 would call this patient, ablation would call this patient back for yet another whole body scan to identify whether there are any leftover active tissues that is available. So many protocols, maybe 6 months in the initial few couple of instances, sometimes an yearly protocol. Please do understand this is expensive. The patient has to stop the L-troxin. Patient would render themselves into a hypothyroid status with symptoms or without symptoms. Luckily, in our country, because of the hot atmosphere, it may not be that symptomatic, but when you go abroad, hypothyroidism is a real issue. So you have this patient periodically coming and getting this thyroglobulin antibody, total body scan, and take the patient up. You have a situation where the thyroglobulin is high, whereas your attempt at I-131 is not able to pick up any focus. This is a situation where your FDG PET is going to help you. FDG PET is an investigation which has recently come in, which has been thoroughly used, misused, and abused by people who are in the treatment field of cancer. Each one have got their own interest, but as far as thyroid is concerned, one definite indication for FDG PET would be a patient post-operatively whose thyroglobulin is increasing with normal or no anti-thyroglobulin antibody, and I-131 is unable to localize the disease. This is a situation where you use FDG PET and localize the disease. And what you do then, you can give another blind dose of ablation or use something else in the form of, again, external beam RT. You have a solitary metastasis which is picked up in the skull. You can put a stamp RT there. You can have surgery if there is a lymph node that is left in the neck is visible on FDG PET. You can go in for excision if it is somewhere excisable. Spine is another important area where you can get metastasis in follicular carcinoma. When you have these kind of spinal metastasis, please understand it's just like a metastasis in skull from a follicular malignancy, going to be highly vascular, and hence surgical manipulation probably would be the last thing that you do in such kind of metastatic bony lesions. Having said that, there is a definite indication to do that, especially in spine, if there is an impending paraplegia. So if such a kind of a situation is obtained, impending paraplegia, you may have to complement that with an MRI for finding out whether there is an extradural component which is going to give the pressure effect onto the spine. In such a situation, if you give a radiation to that area, radiation, as you all know, will create a swelling in that region initially as an inflammatory response. So this would actually augment the patient's chance of an impending paraplegia to be converted into a full-blown paraplegia. So if the extradural component is there in such kind of a situation, it would mandate a decompression. You probably will go one spine above and one spine below and do a laminectomy and do a spinal stabilization. You do an external beam RT in such situations. Whereas if there is no extradural component, you are safe to give this patient an external beam RT, along with after that trying to do a I-131 ablation. Is there any questions at this level? Any questions at this level?
Yeah, anyone can ask? There are many typed questions, sir.
Okay, one question I have seen is what are the indications to do a CT in thyroid? I would say that in general, thyroid, we don't require a CT. In general, the indications to do CT would be a clinical diagnosis of a retrosternal extension, If clinically there is a Pemberton signs positive or anything to suspect a superior mediastinal syndrome, superior vena cava syndrome, you need to have a CT. You also would require a CT if you are diagnosing a patient with a tracheal compromise, be it a infiltration or just a, a compression. You would also require a CT to delineate an extraglandular lesion. I have seen thrombosis in the internal jugular going up to the right atrium, where I have had the occasion to put the patient into pump and bypass pump, and with the help of my cardiothoracic colleague, extract the embolus up till the right atrium. I also have had occasions when the whole of the carotid artery gets engulfed in the tumor process. So these are some of the indications. Some of the indications to do a CT. Adjacent organ involvement, as I mentioned, even I have seen larynx being involved. Hemilaryngectomy had to be decided, etc., etc. So such kind of situations we need to do an CT. One of the questions that would get asked is whether you would do a CCT or just a plain CT. The contrast enhanced is just like giving the patient an iodine. It would be it would be taken up by the thyroid, and hence, if the patient turns out to be malignant later on pathology, then possibly this patient already has gone exposed to one set of iodine, making it stunned for the next procedure. So it's generally a good idea that contrast is not used in CT for thyroid. Does that answer the question? Hello.
Yes. Yeah. Hello.
Hello, I'm with you.
Whoever has asked that question should say yes or no. Okay, so some more questions are there. You can the screen.
What is the ideal post-op date to start thyroxine? I don't think anybody can actually do that. If it is a benign thyroid disease that you are dealing with, maybe on the second or the third day you can start the thyroxine. But if you are having a suspicion that a malignancy, the theoretical answer will be you wait for 6 weeks, get a pathology, you wait for the pathology report to decide on starting. If pathology report is negative, you can start it on the negative malignancy, you can start it on the very next day. If the pathology report is positive and you are contemplating on I-131 studies, be it low dose uptake or therapy, you wait for TSH to become high so that the uptake is complete. So there is no hard and fast rule on which day, post-op day, the thyroxine is to be started. Is that clear?
Yeah, Vishnu Kumar, I should say yes or no. Yeah, he says.
Okay, fine. Next question, please.
Excuse me, sir. Sir, I have a question.
Yeah.
Sir, can a thyroid nodule and a pretracheal lymph node be differentiated clinically?
Well, yes, to a certain extent. But if you ask me a question, yes or no, it may be difficult to answer. If the thyroid nodule is well within the capsule, it has not crossed the confines of the capsule, it is going to move well with deglutition up. You can have a slight difference in the way by which a nodule in the central compartment moves up. We are talking about a nodule on the thyroid at the lowermost part of the inner aspect of any of the lobe or in the isthmus versus a central compartment node at that region. There could be slight difference in the extent of mobility to that. But then on a practical note, it does not actually make any difference. Whether it is node or the thyroid, once you do and prove that there is a malignancy, You just have to go in, and then it doesn't really clinically matter whether you would have a situation of a 2 centimeter node in the central compartment versus a 2 centimeter node in the thyroid. Does that answer your question?
Yes, sir. Thank you so much, sir.
Any other question?
Hello.
Should we do a CT thorax to
Hello.
rule out mediastinal lymphadenopathy? Now, if you have mediastinal lymph nodes are considered to be level 7 lymph nodes, it is very unlikely that the level 6 are missed or negative and you get a level 7 lymph node, isolated level 7 lymph node. If that is the case, every other single thyroid would demand a CT scan. It is not being done. It is not being done. So it is not a routine thing that need to be followed.
Yeah, next question. Somebody is asking a question.
Hello.
Yeah. Is there a genetic requirement for genetic? Yeah, see, I have specifically mentioned about familial papillary carcinoma syndrome. In these kind of situations, it's good to have a genetic study. Other genetic studies are required in, as you know, a red oncogene in a medullary carcinoma thyroid, which I have not dealt with. Maybe if Patta Radhakrishna, permits me to take another set of thyroid or related medullary carcinoma or MEN syndromes, we can discuss that more, because medullary carcinoma forms a different spectrum of diseases which cannot be covered along with this situation. Then there was a question on what about papillary carcinoma in the thyroglossal cyst. Papillary carcinoma in a thyroglossal cyst is a post-operative diagnosis. The schools will be divided in that whether to go for a completion thyroidectomy or not. I personally would look at what the age of the patient, what kind of a background from the patient is coming from, etc., before I decide on this. It's a rare situation, papillary carcinoma diagnosed in a thyroglossal cyst. If you look at thyroid versus thyroglossal cyst, maybe I am prejudiced because we have a huge thyroid load. Our thyroglossal cyst percentage will be 1 in 1,000 versus thyroidectomies. And to have a malignancy in a thyroglossal cyst, it's still more remote. So I don't think we can give a guideline on how you are going to deal with such a situation. But if you are worried about the aggressiveness of the disease and if the patient is very young, I would think that a patient should go for a, based on various factors, I would think that you need to knock off the thyroid to be very certain. Otherwise, we still can, manage with this one. There was a question of question on tracheomalacia. Tracheomalacia is a potential danger in all long-standing thyroid diseases. In fact, the thyroid cartilage has become less supportive, and thyroid is the one which is going to get the support to the tracheal, luminal competency. Now, when do you suspect this? When you suspect this is when you have a long-standing thyroid, number one. Number two is when you have reasons to believe that the lumen of the trachea has been compromised. One of the good tests that can be done, which is easily doable, is in such kind of situation, take a neck X-ray, both epi and lateral. Very often you can see the indentation into the tracheal lumen, both from the side as well as in an anteroposterior dimension. You know that there are a lot of patients whose huge thyromegaly, they have a retrotracheal component and retroesophageal component. In such kind of situations also, this can be a clue that this patient is going to have a tracheomalacia. Having said that, the percentage of tracheomalacia that you see in clinical practice is negligibly small. Negligibly small. But every student of surgery should know what is tracheomalacia. So you anticipate tracheomalacia in long-standing thyroid, in patients who are having Cocker's test, positive, in patients whose lateral X-ray show a tracheal indentation. On the table, you palpate the integrity of the tracheal ring. If they are found to be weak, you can suspect that this patient is going to go for a tracheomalacia post-operatively. What you do now, patient is made towards extubation, patient is made light, and while the neck is ready to be closed but not closed, you ask the anesthetist to withdraw the tube and see whether the patient on a spontaneous level of anesthesia, whether the patient's trachea gets collapsed. If the trachea gets collapsed, it's a good thing that you need to know that this patient is to go for a tracheal collapse, what we call as a tracheomalacia. He is a candidate to be kept on tracheal intubation tube as a stent and extubate it little later. The endotracheal tube acts as a stent. It's not a treatment, by which time after 24 to 72 hours, because the local inflammation, this trachea gets fixed to the neighboring structures and hence maintains its patency. So it is a good idea that the patient is ventilated and taken care of at that point of time. There would be a chance where you may have to do a tracheostomy, but that would be a last thing. Tracheal hitching sutures have been recommended, but literature is very low on that. But many of the examiners would be very keen to ask the question, what else? So you can say that you can hitch the trachea to the local structures by sutures. So this is all about tracheomalacia. I think I'm clear on this also. Any more questions on
Yes.
tracheomalacia?
Yeah, Meghna.
No, sir.
Role of IHC. The role of IHC comes in when you have difficulty in fixing this type of malignancy from mainly in undifferentiated carcinoma. As you know, whenever you have an undifferentiated carcinoma, you have an issue. The cell of origin you need to find out using some IHC. So it would be subject to a battery of tests, be it from soft tissue sarcoma to thyroid malignancy. These are situations in undifferentiated group or some dedifferentiated group, because the problem with leftover thyroid, as this is something which I have forgot. The another reason why the total thyroidectomy is to be done, the recurrence in the next lobe may not be the same malignancy. It could be a dedifferentiated malignancy. Even papillary carcinoma, which was left over in that for a long time, could dedifferentiate and behave like an undifferentiated carcinoma or anaplastic carcinoma. So in such situations also, you would require an IHC to fit in which kind of category to this go on. Regarding the dose of rule of 12, I mean, rule of 10, rule of 12, etc., 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 will be there, in anything, and it can be left to the local. There are a lot of local favorite questions like that, so I won't be
I
able
think,
to.
sir, we have taken too much of your time. 70 minutes is too much for someone to keep talking. I think you're tired, and these questions keep coming in. We'll continue thyroid for some more time, and what the topic will come up tomorrow? So same time, will be okay.
Yeah.
2 o'clock. We'll see you again, sir, tomorrow.
Tomorrow? Okay, fine. Sorry. Tomorrow I have got another webinar which I am committed to it. Can I make it day after tomorrow?
Okay, day after tomorrow, fine, sir. That will fix it
Day
up.
after tomorrow would be fine. I've committed for another webinar tomorrow. That's why. Sorry.
Thank you so much, sir, for being with us and such a intensive lecture. Really, really enjoyed it.
Thank you.
Thank you so much.
Yeah, thank you, Dr. Patta. Thank you.